Hello, everyone. Welcome in.
Hi, everyone. Welcome in. Okay, so welcome to our live Q&A session. We appreciate you all joining us here today and for your interest in PRT and our work at WellBody Psychotherapy and the Pain Reprocessing Therapy Center. At WellBody Psychotherapy, our private practice, we have a team of wonderful therapists and coaches who work with patients with chronic pain, and all our practitioners are trained in PRT. And many of them have training in various other modalities as well, like EAET, ISTDP, CBT, and many more. I know I'm just listing a lot of acronyms right now. Um, the Pain Reprocessing Therapy Center primarily serves as a training center for practitioners offering PRT education, continuing education, advanced courses, and additional resources. We also have an extensive directory of practitioners on our PRT Center website, as well as group workshops for patients. So, my name is Daniella Deutsch. I'm the co-founder of both WellBody Psychotherapy and the PRT Center with my incredible co-founder, Paulina Soble. We're both licensed clinical social workers, and we actually met in grad school. Over the past years, I've trained thousands of practitioners in PRT and have treated hundreds of patients with chronic pain. I'm actually currently involved in a clinical trial where we're comparing PRT to CBT, which is extremely exciting. Paulina and I have actually just written a workbook for teens that will be released in January, which we're thrilled about. So we have many exciting things that are coming up. I absolutely love this work and feel a strong passion for this movement and really this paradigm shift in how chronic pain is treated and understood. Paulina and I are both truly grateful to be a part of it and are humbled by the number of you who registered and showed up today. And with that, I'm going to pass it over to my wonderful partner in pretty much everything, Paulina.
Thank you, Daniela. Welcome in, everyone. Thank you so much for being here. As Daniela mentioned, we met in grad school, so I am also a licensed clinical social worker. I really specialize in pain reprocessing therapy, in treating patients with neuroplastic pain. I've had the wonderful opportunity to co-found the Pain Reprocessing Therapy Training Center with Daniela, where we can have a very multidisciplinary approach to pain recovery and treatment, which has been wonderful to work with doctors and therapists and physical therapists and occupational therapists and all different types of providers that treat pain outside of just being social workers ourselves. And I work in private practice. So I work with chronic pain patients myself and guiding them to recovery. I will mention that I am about 8+ months pregnant. So if I am running out of breath or if I sound like I'm running out of breath, that's why. So that's my disclaimer for today. But we are honored to have you here. We received hundreds of questions, and so we're going to try to address as many as we can in this short amount of time, while also just helping you understand what PRT is, what it looks like in a session, give you a better understanding if you're looking to treat patients with this modality or, receive the treatment yourself as a patient. We won't be able to make it through every question due to all your enthusiasm, but we do have a bunch that we have set up beforehand, and we have this Q&A box here in the Zoom session. So if you see the Q&A box on the bottom of your screen, you can type questions in there. We will get to as many as we can. But hopefully we will just have to do a part 2 of this Q&A sometime soon, answer more of your questions. You also may be subscribed to our newsletter. We send out a weekly newsletter, and we can send a link to subscribe following this webinar. But your questions really help us inform what you might like to hear in future PRT newsletters, what you're interested in learning about. So we really appreciate all the feedback, because if not addressed today, hopefully these questions will be addressed in the future. Okay, so I first want to give a broad overview of what PRT is. One of the questions we received is, what is the most important thing for healing? And really our answer to that is neutralizing fear. So PRT is a framework that helps patients eliminate pain by really shifting from this felt sense of threat or danger to a felt sense of safety. And so we get a lot of questions about how long people will need to use PRT, for how often, why pain chronifies, what can prevent progress. And really, the answer to all of these is that fear is what fuels pain, and healing and recovery will take as long as it takes to neutralize fear. And it actually doesn't matter how long someone has been in pain, but rather how long it takes to reduce their fear. That is the key that we are trying to get to. That is the goal in pain reprocessing therapy. It's not necessarily the goal comes in as pain reduction, it's more fear reduction and responding um, and thinking about your symptoms in a whole new way with, as I said, more of a felt sense of safety. And this word fear, we kind of use as an umbrella term because fear includes anything that makes the brain feel more in danger or feel more threatened. And that can be frustration, that can be preoccupation with the body, it can be annoyance, it can be despair, it can be hopelessness because you've been living with pain for quite a long time. So know that pain is always an output of the brain. When the brain perceives a threat to the body, it generates pain to keep you safe and to prevent further damage. So, our classic example is you put your hand on a hot stove, the brain sends messages to your hand to remove it using pain signals. And so, pain is the brain's means of communication in this sense. But sometimes we experience pain even in the absence of physical damage. There's a really interesting case that is shared by the New England Journal of Medicine about a construction worker on a job site. He had stepped down onto a nail, and the nail went right through his boot and out the other side. So he's super concerned. Of course, he's in agony. He's in so much pain. He gets rushed to the hospital. But when the doctors removed his boot, they noticed that the nail went straight between his toes, barely even caused a scratch. And as soon as this patient saw that his body actually wasn't injured, he was no longer in pain. His fear dissipated, the belief of injury dissipated, and with that, so did the pain. So we see how powerful the brain and our messaging really is. And I like to share that story with patients and practitioners when I'm just explaining the broad concept of PRT. You can think about the equation pain is a sensation with the additional layer of fear. And if we eliminate fear, all that is left is the sensation. So if the brain no longer believes there is a threat or there is danger, then it no longer has to send those pain signals. It no longer needs that threatening communication.
Absolutely. And I'll just add that there are two prongs to the PRT approach that both address this fear that Paulina was just mentioning. So the first prong involves addressing the fears around the pain, right? So all the responses and behaviors that keep fear and pain activated. But then there's a second prong, and that second prong addresses more general fears. So anything in our lives that can keep us in a state of high alert, in a state of fear and hypervigilance, that ultimately keeps the pain alive. And to address these two prongs, we have a system of psychological techniques aimed at retraining the brain to interpret and respond to all danger signals. And when I say all danger signals, I don't only mean pain, but also anxiety, fatigue, nausea, or really any unwanted feeling or sensation, and to be able to approach them with a sense of safety and properly to break that pain fear cycle. We got a lot of questions about what symptoms and diagnoses PRT can help with, and it would be fairly challenging to go through each kind of sensation, each kind of symptom, each kind of diagnosis. So, my suggestion for the clinicians that are here today would be to purchase Dr. Schubiner's book. It's called A Diagnostic Guide for Psychophysiologic Disorders. And that pretty much goes through every single diagnosis. I keep it on my desk all the time. Um, and it goes through, right, every single thing. And my suggestion for patients is to always go to your doctor first to rule out any physical or structural issues, right? Your safety is always paramount. And I want to preface everything that Paulina and I are saying by really pointing out that we are therapists, right? We're not doctors. And we as PRT therapists can, yes, we can help you rule in whether you have neuroplastic pain, and neuroplastic pain is pain that is learned and generated by the brain without a physical issue, but not necessarily are we able to rule out a physical issue because we're not doctors. And the way that we rule in a diagnosis, and we got a lot of questions about that also, is that as a therapist, I'll ask a lot of questions about the symptoms, right? How my patient's symptoms behave and whether they act as physically rooted pain should. So, for example, I'll ask them if the pain worsens with stress or if it moves around their body, or even if it hurts only when they're, vacuuming or cleaning their house, but not when they're doing something with a similar movement that they enjoy, such as, gardening. And these different questions and the answers that the clients provide us with provide both us and the patient with clues and evidence pointing toward a neuroplastic diagnosis. And again, neuroplastic, neuro refers to the brain, plastic refers to the brain's ability to change, to learn, to adapt. And there are so many different terms that you probably all have heard for neuroplastic pain. So TMS, mind body syndrome, psychophysiologic symptoms, right? PPD, they're all really the same thing. And we like to use the term neuroplastic because it feels the most accurate and also offers the most hope, right? So if the brain can learn to generate unnecessary pain, it can also change, unlearn it, and build new neural pathways and new neural connections. I do want to list a couple of common diagnoses that we got asked about and that we often see and work with. So, some of them include back pain, even when there are structural findings like herniations and disc degeneration, neck pain, irritable bowel syndrome, fibromyalgia, osteoarthritis, pelvic issues, foot pain, headaches, long COVID, migraines, chronic fatigue, vestibular issues, facial pain. I mean, I can go on and on. And really, the idea is PRT can help with any unwanted physical sensation, right? This also includes multiple chemical sensitivity and nausea and functional disorders and POTS and so much more. Another thing I want to address before really getting into the PRT process is if PRT can help with physical or structural issues, or what we call secondary pain, because we got a lot of questions related to that. So, if the pain is rooted in a physical problem, obviously a mental health therapist or a coach is not going to be able to eliminate it using PRT alone. PRT in its entirety is used for neuroplastic pain. With that said, there is a concept of mixed pain, right? It's possible for there to be a structural issue and a neuroplastic issue occurring at the exact same time, right? Not all neuroplastic pain fits in this perfect box, in this like perfect niche. It's not always black and white. Neuroplastic pain can fall somewhat on a continuum. Even if there is a structural component, most likely some of the pain is going to be due to fear and resentment. And so that fear and resentment is what PRT can really help with, because all pain has an added layer of suffering due to that fear, resentment, anxiety. So, regardless, we can work with any of that to reduce that layer. So, we can help build awareness around any of the behaviors that occur in response to pain and how those behaviors amplify the volume of the pain symptoms that our patients are experiencing.
Mhm. Yeah, and we receive a ton of questions about that. Well, I have a diagnosis. I believe there's something structural, but there might be this added layer due to my interpretation or my perception of what's going on or other threats in my life. I see we have a lot of questions about that in the chat box right now.
Mhm.
And our cognitive messaging and our emotional response will almost always affect the experience of pain. So I know for myself, if I'm tired and hungry and frustrated after a long day and I stub my toe, it might feel a lot more painful and I might have a much lower threshold to tolerate it than if I stub my toe on vacation after a restful sleep and a delicious meal, right? So even if there is a structural injury, our perception of what's going on in our body, outside of our body, might increase or decrease the intensity or the length of pain that we experience. So many patients, whether there's a clear structural component or not, might feel frustrated, might feel hopeless or in despair. And I encourage patients to ask them how that might be impacting their symptoms. Is problem solving, is preoccupation, is shopping around for multiple clinicians and opinions and doctors making you feel better or making you feel worse in the long run? And PRT is not the only way out of pain. There is value in going to other providers. In fact, we as providers, from multiple disciplines are on a team at WellBody Psychotherapy at the training center. Sometimes this can be the most effective. And I receive a lot of questions about this in my own work, and we received a lot from all of you is it okay to see other types of clinicians? Is it okay to engage in other types of therapies or take medication? Will that negatively impact the PRT work? And I don't think that you have to stop doing everything else in order for pain reprocessing therapy to work. I think you can engage with PRT work and go to a physical therapist or to a massage therapist or do whatever else you need to do, what you are advised to do, what makes you feel good. This might include taking medications as needed, maybe when the pain is very intense. I think what's important to note is when partaking in other work or other therapies, keep an eye on your energy. The most important thing, as we've mentioned, is to promote safety. So when merging other work with PRT, you want to do it in a way that it can effectively shift some of your messaging, right? Some of your fear messaging. If the main goal with PRT is how can we start to neutralize the fear response around my pain? And then if I get a massage, maybe the message is my body doesn't need this, but I enjoy this and it feels good. It makes me feel relaxed or content or at ease. And if you go to a physical therapist, maybe the messaging is about anxiety, right? Can I pair movement and these exercises that I'm doing in the physical therapy space in a safe and gradual and comfortable way with my pain triggers, with conditioned responses to pain? Can I work on my own emotional or anxious response to moving in this way? And when taking medication, when the pain is intense, you might say to yourself, the best thing I can do right now is to downregulate and feel okay, is to take something to reduce the pain. And that is okay. Because when we increase feelings of safety, chances are you will begin to find some inconsistencies with your symptoms. And then you can get further into the PRT work because you can start to build evidence, you can start to distinguish between what is structurally caused and what is neuroplastic. But know that I think our main answer to that question is yes, you can engage in other therapies, you can engage in other work, and that is not necessarily going to negatively impact your progress in pain recovery or with PRT. And I like to remind myself and my clients that approaching symptoms from this lens, from this brain based perspective, is low risk. Pain reprocessing therapy is not going to hurt you, it can really only be beneficial. So do what makes you feel good and what makes you feel safe.
Yeah, absolutely. Paulina, that's a really good point. The fact that PRT is really low risk and can only be beneficial in so many different aspects of your life and your patients' lives. We're going to want to break down PRT and its main components with you. But before we do that, we received a lot of questions about whether PRT is evidence based. And to answer that shortly, I mean, yes, it is. We're currently conducting multiple PRT clinical trials with racially, ethnically, socioeconomically diverse populations. We have one in the VA, we're doing one with groups, and many more. Currently, there's only one clinical trial on PRT that was published, and it was published in JAMA Psychiatry. In that trial, 98% of participants' pain improved, and 66% of participants were pain free, or what we call nearly pain free, after undergoing PRT. And the results are pretty similar in our private practice. We don't have any real data on that, but we have very high success rates, thankfully. So I'm going to put a link to the trial in the follow-up email after this webinar, but for the sake of time, I really want to shift toward questions related to the therapy itself and how it looks like and plays out in practice. Okay, so PRT has 5 main components, which we're going to break down one by one, but I just want to first list them so that you kind of hear what we're about to get into. And the components are: number 1 is education about the brain origins and reversibility of pain. Number 2, gathering and reinforcing personalized evidence. Number 3, attending to and appraising pain sensations through a lens of safety. And for that, we use techniques that some of you might have heard of, like somatic tracking or different exposure exercises. Number four, addressing other emotional threats, right? That second prong of the approach I was referring to before. And number five is gravitating toward positive feelings and sensations. So at WellBody Psychotherapy, right, our private practice, a patient will typically fill out an intake form where we ask specific questions to help us understand whether someone might be a good candidate for PRT. So how their pain presents, if there are inconsistencies, if it increases with stress, what doctors say about their pain, if they have a specific diagnosis, and then what are their beliefs about their pain. And our goal with these questions is, yeah, we want to see if they might be a good candidate, but also how much psychoeducation their practitioner is going to need to provide in the beginning of their work together, right? How much of that first component. So when a patient first comes into a PRT therapist office, whether that's in person or virtually, understanding where that patient is at from a cognitive perspective is very important. So some people come in and right off the bat, they're like, I read The Way Out, I read John Sarno's book, I read Dr. Schubner's book, and I believe with 100% certainty that what I have is neuroplastic pain. And in that case, which is like really exciting for a clinician, the therapist might provide a little bit of psychoeducation just to reinforce certain concepts and help personalize it, but that's about it for that first component. But we also have people that come in who have little knowledge around the neuroscience behind pain and neuroplastic pain and really what PRT is. And they come in and they say, like, I have no idea why I'm in pain, which is also really common. And so when that happens, that first component, that education is really going to be crucial and kind of that first step toward a greater sense of safety. Because once you understand it, once you say, I'm certain that there's nothing wrong with my body, those danger signals can start flipping off. You can start feeling a lot safer. So the first step with PRT is working with the cognitive brain. And we got a couple questions about how PRT is different from basic education, right? Basic pain education. And really, the answer to that is that pain education is merely that first component or that first step in PRT. When learning to overcome any fear, yeah, speaking to the cognitive or the rational brain is definitely important, but education alone does not always help someone get out of pain. And we're going to get to those next components shortly. But we also received questions about whether we see an interdisciplinary future in which PRT practitioners are collaborating with, doctors and physical medicine or rehab providers to treat chronic pain. And Paulina kind of started alluding to that already. And the answer is yes, right? We're already seeing a huge paradigm shift. The alliance between practitioners is actually key in helping people recover. We train multiple different types of clinicians. And what we notice is when doctors and therapists and PTs and other practitioners are on the same team and on the same page using similar language, we can together help patients understand what's going on in their bodies and offer hope and reassurance and safety. In fact, right, we train all these different practitioners, but we also have advanced specialized courses for various types of practitioners. So besides for our regular training where all different practitioners are together in that 21-hour program, we also have specific courses for doctors and nurses that is led by Dr. Schubiner. And we have one for PTs led by a PT, Charlie Merrill. And we have one for coaches, and we have one for mental health clinicians. So you can absolutely incorporate PRT language and exposure techniques and education, regardless of your profession. We even offer the training in both Spanish and French, and we'll send you a link to all these different courses in a follow-up email. But really my point is this education piece, because we're going back to this first component that we're talking about right now. This component, this education piece, can certainly be done with a doctor, a nurse, a therapist, a coach, anyone who could provide a clear and succinct explanation for why we experience pain, and why it can become chronic. Okay, so Paulina, do you want to take over for the second component?
Yes, definitely. So we have that psychoeducation piece. And the second component is searching for and collecting this personalized evidence. So, oftentimes, a clinician is going to ask questions about how a patient's behavior or pain behaves and their subsequent pain response and the patient's beliefs and their pain narrative. So some of these questions might include, did the pain begin during a stressful time? Does the pain increase now with stress? Are there variations in the symptoms? Are there inconsistencies in the symptoms? Does the pain move around your body? And I like to create an evidence list with my patients to help them gather clues and start convincing their cognitive brain that their pain really is neuroplastic and have something to hold on to in moments of fear and discomfort and pain spikes. Have something to remind themselves that their body is indeed safe and they have these clear links and examples, right? And past memories as to how much their brain is impacting the way they feel in their body. And so someone just asked this in our chat and I pasted it in. We call it a discovery survey on our WellBody website for patients to start understanding if their pain may be due to brain processes more than body processes. So this evidence process, it can take time. Sometimes it can take multiple sessions for a patient to be fully sort of convinced. And another question that I saw in our chat and that we receive quite often is, do I need to be fully convinced that my pain is neuroplastic in order to get better? Because maybe I don't yet. Maybe it's hard for me to authentically state that I know 100% this is based in my brain. And of course, working on changing your pain beliefs is important. It is pretty much the whole purpose of these first two steps of the treatment that we're going over. But really, taking the pressure off of yourself, you do not have to believe with 100% certainty in order to recover. In fact, I don't think you will believe with 100% certainty until you are completely 100% out of pain. Certainty can build over time as you increase the amount of evidence that you have and the more corrective experiences you have when working and undergoing PRT. This idea that I just mentioned of achieving a corrective experience brings us to that next step of treatment, the third step, which is really attending to and appraising pain sensations through this lens of safety. And this is what sets PRT apart from that basic pain education. So we worked with the cognitive brain, but now we want to show the primitive brain or the instinctual brain that the body is okay, that the body is safe through exposure techniques. PRT is an exposure therapy. Many of you may have heard about somatic tracking. We received a lot of questions about how to practice somatic tracking. So, first, somatic tracking is an exposure technique. It's aimed at showing the brain that what it has learned to interpret as dangerous is actually safe. So, somatic tracking merges together mindfulness, so being aware of this uncomfortable sensation, then safety reappraisal, which is communicating authentic messages of safety based off of the evidence that, this individual has gathered for themselves. So it can be really, authentic, I suppose convincing messaging for them. Maybe it's not just something that their therapist or their coach is telling them. It's something that they've actually experienced and they've seen their pain increase with stress or whatever it might be. And then the last little piece that we put into somatic tracking is positive affect induction. And this means lightening the mood. It's helping patients attend to sensations through a lighter and easier and calmer lens so that that safety lands, so that we can teach the brain to respond to those sensations without fear, without intensity, without pressure, or maybe without even desired outcome. Because ultimately, when there's less fear, the brain will turn off faulty pain signals, which is what we're getting at here. So, mindfulness, which is that first component of somatic tracking, is a wonderful tool. It helps clients down regulate when they're experiencing any kind of discomfort, whether that's pain or anxiety. We can use guided meditations. We can use breathing techniques. Some that we often use or that I often use with my clients are 4-7-8 breathing or box breathing in order to regulate the nervous system, activate the parasympathetic rest and digest state. And mindfulness is wonderful, but alone, it really only shows mild, moderate, positive effects on chronic pain. And the reason is that somatic tracking can differ from basic mindfulness in that it consists of those other two components. It's really hard to be mindful of something that feels inherently dangerous. So, the education, the evidence building, the choosing personalized and authentic messaging of safety is critical. Having that safety reappraisal piece and attending to the sensations with less intensity is going to be that additional layer to mindfulness that the patient really need to then achieve the corrective experience that we're going for.
Yeah, and this kind of brings us to another question that I noticed that was submitted yesterday, where someone was asking when they do somatic tracking with their clients that it always feels like a big leap for them, for their clients to feel that the sensations are safe because they've perceived these sensations as signs of damage to their body for so long. Now, what sets somatic tracking and PRT apart is like what Paulina was just saying, is that it combines the education, the mindfulness, and other techniques to really systematically help promote safety from both a cognitive and a primitive perspective. So it fuses all those aspects together under this one framework. So we provide the psychoeducation, we help build evidence to really help with these pain beliefs so that when we're doing exposure exercises, our patients can actually feel safe. And we use the exposure exercises to achieve corrective experiences, which actually helps build on those new beliefs that we're forming that the body is okay and to further promote safety and safety learning in real time and to further build on that cognitive foundation. So, you want to attend to the pain, you want to use somatic tracking only when you know you're going to be able to maintain a positive emotional state. So, if your pain is at a level 9 or at a level 10, the chance of you achieving what we call a corrective experience is going to be pretty low. So, we got some specific questions about somatic tracking working sometimes, but not always, or sometimes with one pain or not a different pain. And my hunch is that when people use somatic tracking for something that they fear less or in a time where they're in less intense pain, they're more likely to promote better safety learning. But when the pain is incredibly intense, the only thing that helps is using avoidance strategies or resourcing, whether that's lying down or uh, resting or putting ice over their eyes or going to sleep or taking a shower or even taking a Tylenol or any kind of pain medication. So if I have a client in session that's going through a high pain flare, maybe they're saying that their pain is at a level 8, I'm not going to do somatic tracking with them. What I will do is anything I can to help them feel safe and comfortable. And someone asked about what to do in these cases, right? What do I do with these clients? So I'll usually, again, refrain from somatic tracking and instead help them communicate safety. And like Paulina was saying before, finding authentic messages of safety. So maybe it's hard for them to say, my body is safe, but maybe they can say, this is temporary, right? It's not going to be this bad. What I notice about these sensations is that they ebb and flow. And so, yes, they're strong now, but I will feel better soon. Other things that I'll do with them is I'll do a leaning into positive sensations exercise or a visualization exercise, or I'll talk about something enjoyable to bring their attention away from their pain. Then we also got some other questions where people ask what to do when somatic tracking isn't working. And really, that question in and of itself is typically the reason it isn't, right? The only goal when doing somatic tracking is to relate to the pain with less fear. Nothing else is supposed to happen when you're doing somatic tracking. So if you're saying, it's not working, typically that means the fear is really high, or you're glaring at the pain, or you have an ulterior motive, or you're simply having a tough time letting go and watching sensations with curiosity and ease. And in that case, right, you want to pivot. And so you can pivot to neutral or positive sensations. You can engage in an avoidance strategy. You can communicate safety. If the fear is too high, you're unlikely going to have a corrective experience and more likely to have a re-traumatization. And a re-traumatization is when somatic tracking results in an increase in fear instead of a decrease. So when we say corrective experience, a corrective experience is when you pair attending to a sensation with safety instead of pairing it with fear and danger. We also received some questions about when to do somatic tracking, how often to do it, and also for how long. So you want somatic tracking when the pain is low and when you can maintain a positive emotional state. And this is because you, again, want to maximize the chance of achieving a corrective experience, right? A decrease in fear. Regarding how long or how often, you want to do it for as long as your tolerance allows for it. So you want to really take baby steps. And you could think of how often, somewhat like staying hydrated. Some people like to hydrate slowly throughout the day. I know I always have like this huge water bottle with me and I sip it throughout the day. But others like to drink all their water at once in the morning. And so it's really a case by case basis. And as far as when to do it with clients in a session, if you're here and you're a practitioner, some clinicians will only use somatic tracking after providing psychoeducation and building evidence, while others will actually do it in the very first session, almost as an assessment tool or to help provide education and to start building evidence right from the get-go. And the thing about PRT is that it is more of a framework and not manualized session by session. So we actually got one question about whether there are structured protocols that you follow for different pain types. And really the answer is no. You can deal with every kind of unwanted sensation fairly similarly, right? So Paulina was talking about that equation in the beginning of pain equals sensation plus fear. The goal is always to reduce fear. But I will add that I tend to split symptoms into two categories of diagnoses. So I have the basic symptoms, which is, back, neck, carpal tunnel, plantar fasciitis, pelvic pains, fibromyalgia, all of those. And these are typically chronic because of learning through the unconscious brain. And one way they present is with specific activity or movements. And I saw in the chat box, some people were talking about these kind of conditioned responses of it hurts every time I do something. And typically this is because of classic conditioning and predictive processing. So people will begin to associate maybe sitting or standing with back pain because of memory, learning, and predictions. So for example, this is something I like to ask my clients a lot, like, was there a specific alcohol you drank in college that you can't even look at anymore or you're going to get nauseous, right? That is because of learning and memory. It's not because of the alcohol itself, right? It's because maybe you drank too much in college and you had a really bad night. As for random occurring pain, so not pains that come with specific movement or activity, really my answer to that is the unconscious brain takes in like 6 million pieces of information a minute, and the conscious brain only takes in about 40 pieces of information. So we can't always figure out why we're experiencing pain because the fear that we're experiencing can actually fall under our conscious awareness. And it doesn't matter exactly how it happened. Either way, you can teach your brain to not be scared, right? To fear it less. So with these patients, I'll usually do a lot of somatic tracking or exposure exercises for the symptoms themselves, whether it's that they're just randomly occurring, or I'll have them, sit down if their pain hurts while they're sitting and do somatic tracking with that movement. So that's that first category of symptoms that I see. And then there's that second category of symptoms. And the second category are symptoms that come along with physiological changes. And they sometimes people get a little bit more confused with those, right? The irritable bowel syndrome, the migraines and rashes and fever and swelling, frequent urination, any of those. And we got a lot of questions about those specific symptoms and whether PRT can help. So typically patients with these kinds of symptoms have a relatively lower ability to regulate their nervous system. So in these cases, I'm not going to necessarily use somatic tracking for the symptom itself, but what I'm going to want to do with them is help them regulate before they hit that threshold where the symptom begins. So they might do somatic tracking or watch the fear or the anxiety before the symptom even hits. And just to clarify, I'm not denying that there is a physical change occurring. I'm just saying that the brain is triggering it or amplifying it, right? Their brain's threshold for triggering a physical sensation or a physical response is relatively low. And so the work is going to lie in increasing that threshold so that these physical responses don't get triggered as easily and that they experience less of them.
Mhm.
I know
Yes.
that was a lot.
We're trying to get through all of your questions here. I see there's a lot of great ones in our Q&A chat as well. Something else that I've seen that people ask quite often, both from this webinar, patients that are reaching out to our private practice, is what does a session really look like? What is the flow of a PRT session? And this is something I wanted to address because I think the truth is that it really varies. It depends on the clinician and it depends what each client needs in session based on what the clinician feels is the best way to promote safety learning for that person. Sometimes I will have a client who improves after just a couple of sessions of that pain neuroscience alone, which is wonderful. But others need to build rapport and trust with me first. They need to feel confident from a cognitive perspective. And only then do they feel comfortable enough to even start engaging or trying an exposure exercise. And again, the exposure exercises are used to show and teach the brain that what it has learned to fear is actually safe. So, with PRT, the more exposure and the more corrective experiences, then consequently, the less fear of the pain and then the less pain. So, the main goal with these exercises is to attend to the pain while maintaining a positive emotional state while decreasing fear. And eventually, that's going to help the pain lose its fuel. And so, the only place where PRT is really structured in its flow, or at least I find in my work, is when I'm doing group sessions. So, we offer healing workshops, which are psychoeducational group seminars for patients. You can find the protocol we use on our PRT website. But we go in order of certain components that we are going through now, right? These 5 components of PRT, which I think in a typical individual PRT session over the length of time that I work with a person, I certainly touch on all of them. It might not be quite as structured. But for some of the clinicians here, it may be helpful to give you an overview of our weekly topics that we cover in the healing workshops and the group work. So, the first is psychoeducation and really pain identity, how pain has shaped someone's sense of themselves. The next week, this is an 8-week structured session. So, the next week, we talk about assessment, and that's creating your evidence list, building that cognitive confidence. The next week, we go into exposure techniques. So we use somatic tracking, we use leaning into positive sensations once that evidence is strong. After that, we talk about pivoting as needed. So, the process to understand what tool to use based on pain intensity, which Daniela touched on. When is the right time to use somatic tracking? When should I lay off? When should I take a medication? When should I use leaning into positive sensations? Giving clients more, I suppose, structure around when to use each exercise to make it the most effective. Then we also talk about danger signals outside of the pain, which is that second prong of pain reprocessing therapy. What outside of the pain, but in your environment, might be triggering you or putting you into a fight or flight state and making you observe most everything in your life or environment through a lens of danger, because this includes sensations themselves. Following that, we talk about recognizing preoccupation. I see that someone asked this as well in our chat. I think when you're living with chronic pain, it can become almost second nature to sort of track every sensation that you feel in your body and do so through a threatening or worried or anxious lens because you care about yourself and you're trying to protect yourself. But when we look at anything through that lens, that added layer of fear comes on top of perhaps a neutral or healthy sensation that might not otherwise be painful. So, we want to talk about preoccupation and we want to talk about identifying fears in one's life. This might be feared emotions or feared behaviors and how these influence the chronic pain cycle. In our second to last week, we talk about self compassion, which can have a huge impact on pain recovery. And finally, we discuss relapse prevention, recovery maintenance, what happens if you have a relapse, how to target this in the moment so that you don't feel that you have to fall back into another year cycle of chronic pain. So these are all really important topics in pain reprocessing therapy. However, I'll say in an individual session, it just might not be quite as structured as it is in a workshop. So, as a patient, depending what you're looking for, that can also inform you if you want to go um, in a group or if you want to go with more targeted individual psychotherapy. Someone also asked what you should do as a clinician once you have gone over the psychoeducation and you feel like your patient gets it. So you have that first piece down, they come in, they have a lot of confidence, or you've given them a lot of confidence. And once they do, I think you want to help start building their evidence, build up their own personalized evidence, come up with authentic safety messages, and then start building tools and continue on somewhat in the same order as we do in the healing workshop that I just reviewed. So, if they have enough evidence, okay, great, then we can move on to those exposure techniques that might feel appropriate for you in the session or with the specific client. And we also got some questions about using PRT on your own, outside of a structured group or outside of individual therapy. How can I get back to doing the activities I enjoy, but I avoid now due to fear? So, when using PRT on your own, maybe you're utilizing a workbook or The Way Out, Alan Gordon's book, which is definitely something you can do and something we encourage. I think you want to find a balance between exposure and activity and refraining from pressuring yourself too much. If you put too much pressure on yourself, you run the risk of increasing fear and increasing danger. So just always remember that promoting safety and reducing fear is your ultimate goal. And so you can do PRT on your own, but it can be challenging at times if you have, or even if you have a lot of knowledge, and even if you have that psychoeducation piece. I think we all have blind spots, and we may not be aware of how fear presents itself and how our environment and our responses to our environment and symptoms can impact the perpetuation of both pain and anxiety. So maybe looking at the noticing if you put pressure behind the techniques, noticing what expectations you have of yourself. If there's too much intensity there, I think that can hurt the process of trying to implement PRT on your own. So that's kind of the advice that I'll always give if you're trying to first kind of go at this on your own before working with necessarily a specific therapist or doctor, whoever it might be. Okay, should we get back to those five components? I think we're only on number four now.
Yeah. Okay. So I'll go over the fourth component of PRT, which is really addressing that second prong that I was talking about in the very beginning. And that second prong is those more general fears in someone's life that keeps them in a state of hypervigilance. So perhaps someone's in a really toxic relationship, or they have a bad work environment, or they're having financial issues, or live in an unsafe environment, or even if they're unintentionally engaging in some negative behavioral patterns like Paulina was just talking about, kind of, so maybe it's preoccupation, or it's worrying, or it's putting pressure on yourself, or self-criticism, not being compassionate to yourself. And then there are other things like having childhood trauma or adversity, or an unhealthy relationship with certain emotions, and so much more. And the reason that other fears and past traumas or childhood traumas actually matter is because when you are in a state of high alert, you're more likely to interpret everything, including sensations, through a lens of danger. So, if you grew up in a stressful environment, it's more likely that your nervous system is geared toward threat. And the reason it's geared toward threat is because it's trying to protect you. So, the best way to think about it is like, if you were to be up really late at night and you're watching a horror movie, like when you're in that kind of fearful state, you're sitting on the couch, you're watching that scary movie, and you're just like feeling all keyed up. Every noise in your house or a tap on your shoulder is going to send you into a frenzy. And this is because your nervous system is geared toward threat. It's hypervigilant. So anything that gears your nervous system toward threat can make you more susceptible to pain, right? Anything that puts you in a fearful or more hypervigilant state can increase your symptoms. So we got a bunch of questions asking, besides for just, trauma and all of that, we got a lot of questions about emotions, right? Like how can emotions or suppressed emotions cause chronic pain? And I just want to say it's not the emotions themselves that cause the pain, it's the fear and anxiety that arises in response to the unwanted emotions. So, for example, if sadness or anger is something that you're uncomfortable with, and when the sadness or anger comes up, you're going to feel fearful or hypervigilant, and then you're more likely to interpret everything through a lens of danger. And how this connects to childhood adversity or experiences is, what if sadness is an emotion that felt threatening to you for whatever reason when you were younger? Maybe it wasn't something that was allowed in your home, or maybe there was too much sadness in your childhood, so it triggers you. And so you might learn to suppress or repress sadness in order to survive. And like I said before, anytime that the sadness arises, your brain is going to interpret it as dangerous, trigger its danger signals, whether that's anxiety or pain, and you're going to interpret everything as louder and more threatening than it actually is, almost like that horror movie mode.
Mm. And I think, speaking of that, a commonly asked question that we receive is how to know when you have sort of sufficiently processed your emotions or past traumas so they no longer need to affect you or create chronic pain. And I think one of the reasons this is so commonly asked is due to Dr. John Sarno. Some of you might be familiar with that name. Someone asked a question about how his work, sort of as the father of this mind body connection in pain, is different from work with PRT. And so, to give you some background, Dr. John Sarno talked a lot about the importance of releasing and processing repressed emotions and traumas, and feeling and expressing rage. And although emotions and trauma impact hypervigilance and pain, I think PRT is a bit less about the processing and releasing and more about addressing the fears and shifting toward a felt sense of safety. And this might, vary individual by individual, right? Client by client. But instead of constantly searching for repressed emotions and traumas, it might be more important to become aware of feared emotions and learning how to express them without that fear in the first place, right? Becoming more comfortable with the emotion. So, yes, understanding why the nervous system is dysregulated and how trauma impacts the nervous system is important. I think it can be important to an extent. And what can be more integral to healing is to become aware of why the brain is on high alert, understand that that fear and that hypervigilance that once maybe served this client is no longer needed because perhaps they're in a different environment now, in a different situation around different people, and then learn to move forward with a sense of safety. I do see clients sometimes get caught up with whether or not they have uncovered every unprocessed emotion or trauma, that ends up becoming another source of preoccupation and fear that can ultimately be more harmful than helpful. So keep an eye on the energy with which you or your patients are confronting this work. Is there that energy of fear and preoccupation, or can we move into more compassion and safety and ease? When it comes to pain and those other learned fears, the main point is really to decrease anxiety and fear and shift towards safety. So, some of the questions we received were regarding whether or not it is necessary to work out what is keeping someone or keeping themselves in a pain or fear loop in order to heal from chronic pain symptoms. And to that question, I think the answer is yes. We want to decrease fear and danger. But again, same answer, keep an eye on the energy with which you do this work. You might feel like you need to figure something out or solve something. You need to get to this one specific root that must be the cause for all of the pain. But when we are constantly trying to fix or solve something, we're actually reinforcing a problem, right? We want to address fear. We want to address both the fear around the symptoms and the fear more generally. But I don't think you always need to figure out the why to get better. We don't want to work to feed the same problem as the pain. And we don't always need to revisit trauma. I think that people do need to overcome the fear of the emotions related to that trauma and those that are still living in the body. and they need to be able to experience those emotions without alarm. And you can do that in a number of different ways, but all emotions are felt in the body. So, as a practitioner, can you focus on what your patient is feeling in their body? You can help them track it or stick with it or start to become more comfortable with that. I'll also say that there are different schools of thought on this. This is sort of how I think about it in my work. There's certain trauma informed modalities or approaches like emotional awareness and expression therapy that are wonderful and powerful and definitely necessary for some patients. But I believe you do not have to have this textbook process or recovery from all trauma in order to recover from pain. I think that might be really difficult for certain patients to do. And we actually got a question about how PRT differs from EAET, which is emotional awareness and expression therapy. I think that these two modalities fuse together beautifully. We actually have several practitioners on our team trained in both, and who will work with clients using both modalities. Um, the way I generally see it is that this EAET can be the second step after PRT, specifically if someone has more severe mental health issues or trauma. And for some, this basic sort of boilerplate PRT is enough to get them pain free, while for others, more emotional work might be necessary. So it can be individual. But we group both of these under neuroplastic recovery therapies. I think they're both very powerful. I've gone through the EAET training myself, and I find it very useful in my work with pain patients. So I hope that provides some clarity, although the answer sometimes is it depends on the person.
Yeah. Um, Now I want to just discuss that last component of PRT treatment, which is that leaning into positive feelings and sensations and really just getting your brain used to feeling good. Oftentimes, patients in pain spend a lot of time focusing on negative sensations and negative feeling states, which makes a lot of sense and is really normal, right? Pain is also a lot louder than neutral or positive sensations. So, really, to get the brain better at feeling good, we encourage patients to spend more time leaning into neutral and positive feelings. So we got some questions about, what's the benefit of mindfulness? What's the benefit of meditation? And I believe one of the main benefits of it is that it helps build neural pathways in the brain that are that make you more familiar with these positive feeling states because the brain tends to gravitate towards what's familiar. So we want to make these positive or neutral feeling states more of the default setting, more of the go-to feeling state rather than the negative. So in session, this might look like basic mindfulness or curiously paying attention to neutral or positive sensations. And I noticed that we're really running out of time, but I got one really great question, and I think it's a great question to end with. And the question is, what are some signals you've seen that predicts a breakthrough? And for me, based on my work with patients, really the best sign is when a patient comes in and tells me that they had some pain over the week, but that it didn't scare them all that much and that they were able to be okay and go about their lives. Right? To me, that is even better than when a patient comes in and tells me that they didn't have any pain at all, right? Because if they come in and they say, "Yeah, I had some pain, but like I was okay and I had a great week," it indicates that their fear around their symptoms is really dissipating, which is ultimately the main goal of this therapy of PRT is really shifting toward a felt sense of safety. We also received a lot of questions about pain flare-ups, right? So once you start recovering, it's really possible to have one. And chances are you've been in pain for quite some time and have been responding to the pain with fear repeatedly. So once you start minimizing that fear around one symptom, often patients will experience pain in another area. And this phenomenon is something called the symptom imperative, which a lot of people here might know about, right? The brain become somewhat used to and almost even addicted to being in a fearful state. And so it'll do anything to keep you back there. I really would love to go on and on about this, about relapse, about flare ups, but I do notice that we really don't have any time. So we're going to have to wrap up for today. I do want to say that this Q&A session is recorded. Paulina, do you have any last words before we end?
Yes, we will send you the recording. We can send you some helpful books and links and resources that we mentioned in a follow up email. But just thank you so much for your interest and for your questions. And I'm honored, honestly, to say that we couldn't get through all of them because you are so interested. And we hope to host this again. We hope to answer a lot of your questions in upcoming newsletters and blog posts and really tailor our content to what you're interested in seeing. So thank you for being here. And we hope to stay connected with all of you.
Bye. Thank you.
All right. Thanks, everyone. Bye.